මොකක්ද MCQ උත්තර ටික මම ගම හදුවේ මේ SBR ටික වාසි හතර මට වෙන නෙවෙයි මම ඒක ඩොකියුමන්ට් දෙන්නේ උඹට ඉවරලා අන්තිමට ඉකර ගන්න අද උඹට මේ මේක රෙකෝඩ් එක
යන්නත් ඇවිල්ලා ඉන්නවා සිංහලෙන් අවුලක් නැතුව
අප්පඩ නම් ඉංග්‍රීසි වලින් කරන්නේ
මට අවුලක් නැහැ
උදාහරණ කියන්නේ එහෙම ජාර්නට එහෙමද
හෙලෝ ජාර්නා
ජාර්නට එහෙමද
මම මෙසේජ් කළා
ජාර්න කියන්නේ එහෙම
එයා රිප්ලයි කරන්නෙත් නෑ මචං අපි ඉංග්ලිෂ් වලින් කරමුද
කරනවද
අවුලක් නැත්තම්
හරි අවුලක්
එල එල
So as for the first session of this discussion, I'll be discussing about the 2017 medicine paper. And I have selected out 5 true, false and 5 SBA questions. What I'm going to do is bit of an interactive session. Is it okay with you? I would have trust me over statement. And if you can hear me, Jarna, I would like to join you as well. If it is possible for you to speak up. So in these questions, I will give some general tips if, what I used for my exam before starting the session. In the MCQs and SBAs, first you have to select the order. What I did have to mark at least not when you are marking true false, you have to mark at least 60% of at least 60. More than 60 you have to mark, because if there are 600 stems and you have marked only 50 stems, if five of those are wrong, you are going to only get 40 out of 100. It's not enough, no? So at least you have to mark at least 60 if we are very sure about those 60. If not, better to mark more than that as well, because we might know sometimes we might think that the answer is pretty much correct, but it can be wrong. So better to mark at least 60, ideally more than 60, but try not to mark over mark as well, because it can backfire as well. And those things are the mainly I want to talk about regarding generally about the MCQ papers. It is related to almost all 5 streams, all my 5 subjects. So we'll go through the MCQs, and I'll be discussing a little bit about the topics the questions have been asked as well, because no point of going through only the answers of to these particular questions. So first question is, so we'll go through the questions first. First one has been asked, about CSF, mainly about the meningitis things, and second one CIDP, the TBS kind of things, and then cardiac murmurs and hypertension uh, and radiological features. Those things in the first five MCQs, and in the SBS, there is about some neurological one first in the first two SBS and first three SBS, and then about acute coronary syndrome and cardiology questions, two cardiology questions. So there are some categorized ones regarding the topics of these MCQs as well. But if you have time, you can go through those as well, because those topics have to be covered before the exam. What I did was I created my own uh, categorized MCQ things like the topics which has been asked in each year from 1 to 50, and I went through each of those topics uh, as much as possible. The commonly asked topics we have to go through at least several times or at least once. So we'll go to the first question: low glucose and high polymer of nucleosides. And another thing you should do is you should highlight uh, the terms, the defining terms which has been given in the question. So you have to give some priority to those words and uh, get the full idea about the question as well. So low glucose and high polymorphonucleases means neutrophils. Uh, in CSF indicator. අලේ මොනවද උත්තර ගත්තේ?
මම ඕකට අර මේ ICJ meningitis එක තමයි හිතුවේ. කියන්නේ මේ වෛරස් දෙක වැරදි කියලා ගත්තා. අනිත් දෙක ගැන අයිඩියා එකක් නැහැ.
හරි. එතකොට අපි මේකේ නයිසීරියා එක තමයි ගත්තනේ. ඔව් අනිත් එක ෆෝල්ස් කියලා. අපි මේක දැන් සුට්ටක් පැත්තකින් තියලා මේකේ පොඩි මේ ඩිස්කෂන් එකක් ගැන සුට්ටක් බලමු. ඒ කියන්නේ දැන් ඔය මේ චාන්සර්ගේ Chance's selection notes are very much better for the neurology questions. He has covered almost all the topics with almost all the MCQ points as well. So if you have time, if you have no time, you better to go through those lectures at least once, if possible, because he has given all the MCQ topics and points as well. So regarding CNS infections, but there are three main conditions regarding infections, that is meningitis, encephalitis, and meningoencephalitis. What we need to thoroughly know about is the meningitis management and as well as the encephalitis management and the complications of that. So meningitis, what we call the typical symptoms are the headache, severe headache, photophobia, and nuchal rigidity or the neck stiffness. So those three symptoms altogether called as meningism, which is the sign of other symptoms of meningeal irritation. So in that meningitis, the meninges covering the brain are the ones which has been infected and inflamed. In encephalitis, the cerebral matter, the brain matter has been infected or inflamed, not infected, inflamed. And meningoencephalitis, both meninges and the brain matter has been inflamed. So these causes of CNS inflammation can be categorized as infective and non-infective causes. So what we mostly know are the infective causes, but there are some other non-infective causes like malignancies. In those malignancies like paraneoplastic, which occurs as a part of paraneoplastic syndrome. And some inflammatory diseases like SLE can also cause CNS inflammation as well. And autoimmune conditions like NMDA receptor antibody, autoimmune encephalitis, and those things also can cause CNS inflammation. So the important things are the causes, like does not directly ask because these are straightforward things, but we can broadly categorize as bacterial, viral, and fungal, the infective causes. And cerebral infection, the meningitis can also categorize according to the onset of symptoms like acute or chronic, and like that. And if there was a SBA question which has been given with a scenario, These symptoms are, I think, very much important to identify what type of infection uh, an SPA can come like that. Uh, because each of the clinical clues give us the possible causes for the for the subsequent management and of the disease. So we know that these things are mostly meningitis is mostly covered in the pediatric part, but we have seen that in medicine also the meningitis comes again and again. So meningococcal infection, we know that there is a petechial rash that in the buttocks and region, the petechial rash, and pneumococcal infection that can cause with skull fractures, severe disease, and there was some previous SCQ and also previous SBA as well regarding pneumococcal meningitis following a skull fracture, nose knock, something. I can't remember exactly. And immunocompromised patients, we know that opportunistic infections, and those are the uh, main causes of meningitis, and this is the one this question has been based on. So the top one is from the Kumar and Clark, and first we have to go through the normal parameters like normal parameters of CSF. So usually CSF is clear, and there are less than 5 mononucleosis. If his lymphocytes are less than 5. Uh, polymorph cells, which are neutrophils, there should not be any neutrophils in CSF in a normal person. And proteins 0.2 to 0.4 grams. I don't think that the cutoff should be remembered. And glucose levels usually two-thirds to one-half the blood glucose levels. So these are the normal things. We should know the normal things before we go into the abnormal things. So අලේ වයිරල් එකකදී කොහොමද එන්නේ මේ ටික?
වයිරල් එකකදී මේ ලිම්ෆොසයිට් වැඩි වෙනවා, ග්ලූකෝස් ලොකුවට වෙනස් වෙන්නේ නැහැ, ප්‍රෝටීන් ලොකුවට වෙනස් වෙන්නේ නැහැ නේ.
So, in viral infection, viral meningitis, appearance is more or less same. Mononuclear lymphocytes are increased. Polymorphs neutrophils are usually not increased, and protein is not much elevated, and glucose is also not much decreased. As a slightly increased protein or slightly decreased blood glucose can be seen. Jarna, can you tell me about how these parameters change in bacterial meningitis?
Glucose will be reduced, and the protein will increase, and polymorphs will be, wait, will it increase? I forgot that.
You can go through each by each. Appearance, how would be the appearance?
Appearance will be clear, no? Or
Can be, yeah, little bit of
cloudy.
cloudy, no? Because
Yeah.
yeah, mononuclear cells, lymphocytes,
It will be high, no?
yeah, it usually increases. Polymorph,
It's polymorphs that I don't know.
yeah, it's better if these mononuclear cells and polymorph cells, we are not familiar with those, no? So
Yeah.
if one thing, if a term like this comes, you have to write the proper, the familiar term we are using. The mononuclear cells are lymphocytes.
Yeah.
Polymorph cells are neutrophils.
Then it will be increased.
Yeah, it is increased. Protein.
Protein will be increased and glucose will decrease.
Yeah. So the appearance is given rise by the proteins. If the proteins are higher, the appearance will be cloudy, and then ultimately it becomes very turbid. So what you said was correct, and pyogenic means purulent, which is bacteria. Turbid, lymphocytes are not much elevated, but it is slightly elevated. Polymorphs, neutrophils are highly elevated, and proteins are also elevated, and blood glucose is also decreased. Tuberculosis, TB, meningitis.
TB වල බං appearance එක turbid වෙනවා. ඒක ෂුවර්. ලිම්පොසයිට් වැඩි වෙනවා.
Hmm.
පොලිමෝප්ස් ලොකුවට වැඩි වෙන්නේ නැහැ. ප්‍රෝටීන් අඩු වෙනවා නේද? ග්ලූකෝස් ගොඩක් අඩු වෙනවා.
Hmm.
ප්‍රෝටීන් ෂුවර්.
So, TB is also, it is bacteria. No? So, what happens is the appearance we'll talk about with the protein altogether. It's much easier to understand. So, TB is a special kind of bacteria. No? It gives rise to more of a chronic infection, more or less causes chronic infection. So, we know if if an acute infection occurs, acutely inflammation occurs, the first cell lines to go up are the neutrophils. In most of the conditions, neutrophils go up in the earlier stages of chronic. When there is a chronic infection, in the earlier stages, the neutrophils are increased, and later on, the neutrophils are not much increased, but the lymphocytes become increased. So usually at the diagnosis of tuberculosis, it has to be some time has been should be passed. So it is later in the disease course of disease we are diagnosing tuberculosis meningitis or any other tuberculosis type, tuberculosis the lung infection or any other thing. So if we do uh, CSF analysis of a patient suspecting a tuberculosis meningitis, it is later in the course. So the neutrophilic phase has been passed already. So the predominant cell count would be lymphocytes, but neutrophils can be increased as well. And we know that, so these two have been answered. Protein, it is a bacteria and it is a it is active and it works over a long time. And the proteins in the CSF will be very much increased, more than a normal other types of bacterial meningitis. So proteins will be very much elevated and it gives rise to appearance. It is very cloudy appearance of the CSF. And glucose will be also reduced with that as well. Did you guys understand?
Oh,
Yeah.
A bit viscous, almost viscous. Lymphocytes are the predominant ones, and then lymphocytes are the predominant one. Neutrophils are also increased. Proteins are increased, and blood glucose has been reduced. So the other one which has been asked here is the fungal one, which is not much familiar for us. It has not been given in this one as well. So I'll go through it. Fungal infection is also more or less acts as a viral meningitis. Uh, the appearance is more or less clear or cloudy can be. White cells are the predominantly lymphocytes, and proteins also normal or high. Glucose is normal or low, and opening pressure it's not needed for us. It, we can remember it as it's almost like a viral meningitis picture. Uh, so you guys now have that understanding about how the CSF parameters changes in each of these infections, right?
Yeah.
Yeah. So if a patient suggestive symptom suggestive of meningitis comes to you, what are you going to do? So Dharma,
Hmm?
if a patient comes with symptoms suggestive of meningitis, what are you going to do?
Yeah.
How are you going to manage this
Uh,
patient?
we have to first confirm it, right? So we take the no, we can't take. We do the CSF analysis.
Uh, okay, go on. Describe me what are you going to do and what are things you're going to do. If not correct, I'll correct it later.
Okay, and then I forgot man.
No, just stick to the basics. So when the patient comes with symptoms and signs suggestive of meningitis, next what we are going to do is the investigations, basic investigations. So what are the investigations we are going to do for this patient, for patient with meningitis?
We have to do CSF analysis.
Mm-hmm.
We have to check the blood for glucose,
Okay.
and
Are you going
then
to take blood flow glucose before CS analysis or after CS analysis?
Before.
Why?
The blood glucose something changed, right? When we do the check, do the lumbar puncture and check CSF.
Why?
I can't remember why.
I'll go through that as well. So what else are
Okay.
you going to do?
Uh, and then we have to test for TB also. It can be
Okay.
TB meningitis. Okay.
Okay.
And
If
then
patient presents with high-grade fever for 2 days duration with photophobia, and on examination, the kerning signs and routine signs or signs are positive. So your investigations are uh, blood glucose, CSF analysis, and CSF for TB infection. So what else? Ale, what are you going to do? What are the investigations first you are going to do?
full blood count.
Yeah, full blood count. ඊළඟට full blood count.
See, CRP hari ESR hari දෙක ඒ දෙක කරා.
ඊට පස්සේ CSF analysis final test
CSF analysis එකක් කරනවා.
කොයි විදිහට කරන්නේ?
මේ ඇන්ටිබයොටික් පටන් ගන්න කලින්.
සාමාන්‍යයෙන් කොච්චර if the patient presents to you at 8 o'clock in the morning, when are you going to administer the first dose of antibiotics?
ඒක not sure about.
Then acute meningitis, no, the picture I gave us acute meningitis. So this is an emergency, actual neurological emergency. So if it is a severe infection in the in the meninges, and we have to administer the antibiotics as soon as possible. CSF analysis, if it is possible, we can do a CSF analysis, but we should not delay the administration of antibiotics until we do a CSF analysis. So if the patient presents with these symptoms, what I'm going to do is I will make sure that patient is dynamically stable. Then I would get the IV access first and very quickly, and I will do the basic investigations like full blood count, CRP, and hear electrolytes or something, because there are some complications of that is like SIADH and things, and then blood culture if possible. Blood culture with all those things, and I will administer antibiotics as soon as possible. We should not delay. If possible, we should take CSF before administering antibiotics, but it takes time. So what we have to do is we have to take these investigations first, and then administer antibiotics, and later on we can do a CSF tap if possible. Because we need senior help for that. I'm talking about this because we need those things for our long discussions as well. So these things are the things we have to do. Okay, you got it. And the other thing was why we do the blood glucose level checking before doing the spinal tap first. That is because spinal tap is a painful situation, and it is a stressful situation, and with stress blood cortisol levels will be increased. So we know that cortisol is a hormone which increases our blood glucose levels. It is a stress hormone which increases our blood glucose levels. If we do the CSF analysis at 8 a.m. and take blood glucose at 8:30 p.m., 8:30 a.m., the CS blood glucose levels here and here, we are going to compare these two. No, it will be this will be wrongfully low. So what we have to do is we have to take the blood glucose at least about half an hour before the CSF. This is very much. This will be asking the PED questions if you are given a meningitis case. So you should know this. We have to take blood glucose before doing the CSF analysis, CSF tap. Mm, so management. Uh, so if the patient, I forgot to mention that there are bacterial and viral meningitis causes commonly. So viral meningitis does not have significant sequel, long-term sequelae or complications. Usually they resolve on their own as well. But we can't be sure that this is a viral meningitis. So every every patient suspect of meningitis, we should treat as a bacterial meningitis. So these things we talked about the investigations, and uh, the other thing I wanted to tell you was that we have to give in adult meningitis, we have to give IV dexamethasone with the first dose of antibiotics as well. It causes the uh, it causes reduced inflammation within the meninges. But this practice is not being done in the pediatrics, and you should know, remember that as well. The IV dexamethasone or the steroids are only given in adult meningitis. තේරුණානේ දෙක ෂේප් නේ ඒක වෙන්නේ. අලේ
Yeah.
හරිනේ. You should remember that. Only in adult medicine we are giving steroids with antibiotics in the meningitis. So see, brain imaging we can do that, but it is not done as the initial investigation. We there are many other things we should do as first line things. Then these things are and the antibiotics. So what we are giving is mostly for any type of, you should know these things, but any type of meningitis, what we are giving is cephalosporin, cephalosporin, like ceftriaxone or cefotaxime, with or without vancomycin. So if you know that, it is enough. I also can't think of anything else. එතකොට මෙතන කාල ෂේප් නේද?
ඔව්.
මේ මං වෙලාව ගන්න වැඩිද කොහොමද අවුලක් නැද්ද?
නෑ නේ. ඔහොම හොඳයිද?
Zana, is it okay for you? I'm taking a bit of longer time because I am.
Oh no, it's fine. Like it's helpful for MCQs or like for cases also, no? And
Yeah,
if other
that's why
MCQ comes,
that's why I'm going to a bit of details.
take your time. It's okay. I don't mind.
And the other one was, this is important in pediatric. You ඔය දෙනටම පීඩුත් තියෙනවද?
ඔව්.
Zana also has feed, no?
Yeah, I have eaten medicine now.
So okay. So the other thing was the chemoprophylaxis. In meningococcal infection, we have to give chemoprophylaxis for household contacts with rifampicin or ciprofloxacin, and doses you don't have to know. This can be asked in pediatric long case, because meningitis and in our cases, even encephalitis has been given in pediatric cases. I think Satsara or someone had encephalitis, a child with encephalitis. So the other
Really?
yeah. Satsara had encephalitis. Devinda had leptospirosis. Yeah, some upset cases has been given. So I don't think for the repeat one they will give those things, but meningitis definitely they will give if there are patients.
Yeah. Okay.
So encephalitis, you know that it's the inflammation of brain matter. So the important things which can be used to differentiate from meningitis is the focal neurological signs and seizures. This can occur in meningitis with local inflammation of focal cerebritis can occur with meningitis as well, but it mostly occurs in encephalitis. So these things are the ones we can use to differentiate meningitis from encephalitis. So, and there will be some cerebral dysfunction on EEG as well, because it should be there, no? There are some dysfunction. It's inflammation of brain. So pathogenesis wise, this is the pathogenesis wise, the like we are talking about the severity of the diseases. This is complete opposite of meningitis. In meningitis, viral inflammation is Viral meningitis is not much a big deal, but the bacterial one is the problematic one. In encephalitis, it's completely opposite. The bacterial one is not, yeah, it is a bit of bad thing, but the viral encephalitis is the one, this one we are talking mostly about, because viral encephalitis there are some permanent and severe neurological post neurological sequelae. So we have to treat it then and there. So there are two types of encephalitis which can occur after viral in a viral infection, which is primary infection of primary acute viral encephalitis. It is the virus is directly invading the brain. The other one is the post-infection encephalitis, which can occur with varicella or any other infection due to the cross reaction of antibodies. From the antibodies produced for the infective organism cross reacting with the cerebral matter. So that is a post-infective encephalitis. Those two are the main things, and the vasculitis in the varicella zoster and also can cause uh, encephalitis. It's not needed. So investigations more or less same, but we have to do a EEG if possible. It's not; those are not the first things we do. We have to give the antivirus first, and then later on we can do these investigations as well. And this one is very important. Can you guys see? I think this was asked in the previous MCQ or in our MCQ. I can't remember. Chang sir told this about multiple times. The main two things, main two organisms of encephalitis we are talking about are the herpes simplex, HSV, and JE and flaviviruses. Flaviviruses, dengue, JE. So herpes simplex, HSV, it has a predilection for temporal lobe. The temporal lobe, like this picture, this temporal lobe, it has been affected. It is the typical place for HSV encephalitis. And in flaviviruses, the JE and dengue viruses, they are usually residing in basal ganglia, and they are causing inflammation in basal ganglia. So you should know that. I think I also used to memorize this one, and I can't remember exactly. I think in herpes HSC there will be hemorrhagic CSF as well. I think there will. I can't remember exactly, but I think there will be blood RBCs in CSF as well. I'll check it and let you guys know after the session. I think there will be a hemorrhagic CSF in HSC. I guess as far as I can remember. So in the management, this is asked in our SQ, uh, I can't feed that, no? That prophylactic anti-seizure medication was given as something. I didn't write that. So in CS we have to give anti-seizure medications if seizure occurs, and in empirical intravenous antibiotic as plus antibiotics plus acyclovir. We have to give that for HSV infection. We have to give that. You, if the patient, a pediatric patient comes with symptoms and signs which are not inconclusive of meningitis, we should always give acyclovir along with antibiotics. And steroids can also be given. So those things are the main two things regarding the infections of inflammation of CNS system, and the other one is the autoimmune encephalitis, which I talked a little bit previously about NMDA receptor antibody encephalitis and limbic encephalitis. Those things I don't think they will be asked in our exams. That film on brain on fire was the patient had this disease, NMDA receptor antibody or encephalitis. And that's it. And intracranial suppuration, which is abscess in the brain, you know that what are the radiological features that you can see in a intracranial abscess? If you do a CT, what would be there?
Can you repeat? I didn't hear what did you say.
If a patient has a intracranial abscess,
Yeah.
cerebral abscess,
Mm.
what is the radiological feature we can see in a CT
Well,
scan?
well defined that margin, no, like
Yeah, what is that called?
mm,
Ale?
Done never.
Ring enhancing lesions.
Ring.
Ring enhancing lesions. The
yeah,
margins of the abscess will be very much hypertrophic, not hyperdense area. It's an hyperdense area. And it's well defined. So if abscess can occur, it acts as a space occupying lesion. So all those symptoms of increased ICP will be there: headache, epididyma, sixth cranial nerve palsy, which is a false localizing sign. I think you guys can remember because if we get sixth cranial nerve in our short cases, isolated sixth
mm,
cranial nerve palsy, one differential diagnosis would be isolated sixth cranial nerve palsy. There are actually two differential diagnoses, which is diabetes mellitus, diabetic neuropathy, mononeuropathy, or increased ICP. So how you guys can differentiate these two conditions in on examination? Sixth cranial nerve palsy due to diabetes mellitus or due to increase in
mm-hmm.
pressure.
Fundus. No.
How I going to differentiate from fundus?
Mm, mm.
What would you see in ICP, increased ICP in fundus?
Oh yeah. The oh wait.
Diabetes.
Papillary,
Heavily.
papillary. And in diabetes, what would you be able to see in diabetes? Diabetic fundus.
Total retinal.
Yeah, features of
Total
diabetic retinopathy, no?
disease.
The
Yeah.
proliferative and proliferative features. So that's how are you going to differentiate it. If isolated sixth cranial nerve palsy comes, those two are your differential diagnosis, and you should offer fundoscopic examination in the short case.
Mm,
Because it's common sixth cranial nerve, isolated sixth cranial nerve palsy is also a common short case. So management, we know that if ICP increase, we should not do LPs, and other things are pretty much same, but we have to give long courses of antibiotics longer than meningitis or encephalitis, and also if it is a large abscess, we should drain those as RNA.
okay. Mm-hmm.
So we go to the question. So aspergillus meningitis, true or false?
Low glucose.
Aspergillus is what?
Fungus.
Fungus. So it's more like a neutrophil. So low glucose, high volumos, more like a bacterial or
Yeah.
tuberculous, early tuberculous, early TB, but which usually in TB lymphocytes are the ones who increase,
High.
but in early TB, what we talked before, the neutrophils will be elevated. Early TB or bacterial infection. This picture is suggestive of early TB or bacterial. So aspergillus is fungal, fungus more or less like virus. So this is false.
Yeah.
Coxsackie is virus, so it is also false. Early TB, we discussed it before.
True.
In early
True.
infection, it's true. EBV meningitis,
False.
false. Neisseria, true.
True.
Arine.
Mm.
Ilenka, regarding AIDP, acute inflammatory demyelinating polyradiculopathy. So basically GBS, what we are talking about. There are other conditions, but commonly we are talking about GBS. IVIG is first line treatment.
True.
Yeah.
CSF performed at the onset of disease.
No. After 10 days only. Stop.
Okay. Diagnosis confirmed by nerve conduction studies.
True.
Bladder involvement occurs in the first week of the disease.
Mm,
You guys not sure? Sensory
no.
involvement occurs in a subset of patients.
Balls.
Yeah, right. True.
True or false? Okay. So we'll go through the discussion and then we'll come back to the question again. So acute pleural paralysis. So the name. This is also a long case. So I'll go into the details a bit for this one as well because we can get GBS as a long case. There are patients. So if a patient
Mm-hmm.
presents with acute pleural paralysis, there are three main differential diagnoses we have to consider. Which is AIDP, the GBS picture, and spinal cord damage. In the acute period, there will be spinal shock for few days, and it will be present as acute pleural paralysis, and later on, it will become a upper motor neuron type spastic paralysis. And the myasthenia gravis also, we know it's a synaptic thing. It is low motor neuron. It is can also lead to flaccid paralysis, which is low motor neuron type. Okay, now. So you
Okay.
should know have some idea about how to differentiate these two things. So these slides I have taken directly from the Chancellor's lecture. So AIDP and cord lesion. So usually we know AIDP is a symmetrical ascending paralysis. It comes
Mm-hmm.
from usually comes from lower down to up, but it's
Okay.
not always same. No? So cord lesions are also usually, if, if it is the cord is completely damaged, it's symmetrical one. But it can be asymmetrical as well if there is a partial cord damage. It can be asymmetrical as well. Sphincter dysfunction, that is bladder bubble, usually it does not occur in AIDP, but it can occur. So it is not zero. But we know in cord lesions, if the patient has spinal cord injury, we know that the patient get early bladder bubble involvement in patients with spinal cord lesions. So it's early. Plantar reflex, uh, low motor neuron, typical low motor neuron type, which is flexor. And in what this thing we can use to differentiate spinal shock from other things. Yeah, even in the case of spinal shock, in cord lesions, the plantar reflex will be extensor, and the patient may be flaccid, but plantar reflex will be extensor, which is indicative of upper motor neuron type. This one we can use to differentiate this from AID. Sensory signs, none. This chancellor at that time, he told us there are only sensory symptoms, but no sensory signs in patients with
Okay.
GBS. But later on, he did something in the clin mark. No, I can't remember. 1 or 2 months before the exam. In that, he told us that there are some patients have sensory signs as well. Initially, he told that there are no sensory signs, only sensory symptoms. But
Mm-hmm.
later on, he said that he only told those things because we have not matured enough to understand that those are something but blah blah blah. However, the
Mm-hmm.
thing is, even it is mentioned as none here, a set of patients get sensory signs. You should remember that. Yeah? In
Okay.
cord lesions, you know that there will be sensory level. You can find out in the examination. Cranial nerve palsies, there can be cranial nerve palsies in ADP. We know that ascending paralysis can affect lower limbs, then upper limbs, respiratory muscles, and later on the facial muscles and the cranial nerve. So there will be can be cranial palsy as well. But spinal cord lesions, there are none. The brain has the spinal cord, the cranial nerve has been spared and it is lower down. The lesion is lower down. So
Mm-hmm.
overall clear on it.
Oh,
Yeah, I understood.
I went into much details because these things we need for the long cases as well.
Mm-hmm.
So GBS, we know that this is a post-infection disorder, which I like talk about the post-infection. post-infectious encephalitis. It is the similar pathophysiology which occurs with the cross-reaction of antibodies, which form against the infective agent, cross-reacting with the myelin sheath cells. So it occurs commonly after respiratory tract infection or a diarrheal illness. Diarrheal, the Campylobacter is the commonest. Other than that, there are some other etiological factors like CMV, DB, HIV, mycoplasma, and hemophilus. So those also can cause post-infectious GBS as well. So this one is important. These are the sensory signs we talked about: pain, numbness, and paresthesia. And then it progresses bilateral symmetrical from lower limbs, upper limbs, and cranial nerves. So usually uh, occurs a bilateral symmetrical type weakness. Okay, and this one is also very important. Global ereflexia. There will be no reflexes, and if a patient uh, if you get a case of acute flaccid paralysis, and or even in the short cases, if the patient is flaccid and the reflexes are not evident in the patella, the reflex examination, you must reinforce and do the reflex examination again. If the patient, we are doing upper limbs, you should ask the patient to clench teeth, or if we are doing the lower limbs, you can ask the patient to clench teeth, or pull the fingers apart. You know that one. You should do that. If in the short cases, you must have to do that. And
මොකද්ද බං?
no sensory signs, it's not true. Even though Chancellor said that time, there can be patients with sensory signs, but mostly not. So progression wise, there are two things. There will be acute AIDP and CIDP, acute inflammatory demyelinating, that one, and chronic one. It is based on the duration of progression of symptoms. So usually AIDP, which is GBS, does not progress. The symptoms does not progress beyond 4 weeks. Usually it reaches a peak at 4 weeks, then gradually comes down over weeks to months period. If the progression occurs beyond 4 weeks duration, we call it CIDP, or chronic inflammatory demyelinating polyradiculopathy. Okay. So complications wise, the worrying complications are the respiratory muscle paralysis and autonomic dysfunction. So respiratory muscle paralysis, it can lead to exhaustion and type 2 respiratory failure. And autonomic dysfunction, mainly the blood pressure fluctuation and arrhythmias are the ones we are worried about. So in the management, we have to monitor the patient for these two complications. So before management, I will go through the diagnosis. So as you said before, usually there are typical symptoms of GBS, and both nerve conduction study and CSF estimation should be done after 10 days of 10 days of onset of symptoms. There will be no abnormalities in those two investigations if we done early in the course. So it is done after about 10 days. Okay. So in nerve conduction studies, there will be demyelinating fevers, but with that alone, we can diagnose that this patient is having a AIDP. We have to combine it with nerve conduction study, clinical picture, along with the CSF study, which is done after 10 days. So there will be albuminocytological dissociation in the CSF, which is albuminocytological means high protein levels and no cells will be there. High protein, no cells. Usually proteins to be elevated, there should be cells, no? But in this situation, there will be high protein levels without much cells. It is usually does not occur in other situations. හරි නේද?
Okay.
ඔව්.
So management, uh, if you are answering for the long case also, if you are categorizing your answer, categorize your answer and give it in a categorized manner, we can give a proper and structured answer which the examiners are like. So in the management, we have to do these things: monitor the progression, prevent and manage complications, general affairs, specific therapy, and rehabilitation. Any neurological condition, we should end the discussion with a part of rehabilitation. Any neurological disease, stroke, meningitis, VBS, anything. So progression-wise, we know that there are two complications which can occur. Dreaded complications are the respiratory muscle paralysis and autonomic dysfunction. So for that, we have to check for the muscle strengthening. So we can check the limb power within the normal usual way, and also one thing Cancer did was we had a patient in the ward. Cancer asked the patient to flex his neck, and he, against his resistance, which he put on its forehead. So if patient has a good ability to flex his neck, that means he has good respiratory reserve, because neck muscles are also used in the forced inspiration. හරි නේද? So other than
What
that,
inspiration?
forced inspiration, if the patient is,
Okay.
yeah, and it is a rough one, but it can be used in the clinical setting. If you were asking the long case, you can give that answer as well. How are we going to monitor clinically? Other things are the vital capacity by respirometer, single breath count, and single breath count. So in the long case, if you were given a patient with any type of paralysis, you must do this one. I got that case in the ward, and I had to present this one, but I had only about 10. During the ward rounds, I had to take history and present it. I could not do this, and I had to present it to answer.
How
So
do we do this?
we do this. We ask the patient to take a deep breath and count as much as possible you can, but it should not be much hurried as it. Like 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Until his breath lasts, he should count. So it has to be more than 25, and you should do this in the exam. I have written in my case book that with the bad word as it. So these are for the monitoring, and monitoring initially we have to do frequent monitoring, and later on we can decrease the frequency of monitoring as well. So this can be asked. These things are not reliable. The peak expiratory flow rate, pulse oximetry, ABG, and respiratory rate are not reliable to detect early respiratory muscle weakness. And autonomic dysfunction, we have to check the blood pressure, heart rate, and blood pressure and heart rate frequently. If continuous monitoring is available, we can do that as well. So general care, otherwise, if the patient is having facial nerve palsy, we have to provide him artificial tears, because it can cause corneal ulceration if it is exposed to air. The eyes are continuously open and exposed to air. And also with any type of paralysis or weakness, patients are bedbound and they are more prone to get DVT. So we have to give DVT prophylaxis as well, with stockings as well as heparin if there are no contraindications. And swallowing dysfunction also we have to do with, we can do a swallowing assessment, and if there are difficulties swallowing, we can go for NG feeds as well. And then skincare, as the patient are bedbound, they can get pressure ulcers and all those things, and bladder bulk, and if those things as well. ඊට පස්සේ specific therapy, there are two things we can do as specific therapy, IVIG as well as plasma exchange. Both those two things have similar efficacy, but we do not do both things together. We go either for either IVIG or plasma exchange. We do not do both things for same patient. Okay.
Okay.
And IVIG dose, I think you should know that if you get a long case, not for the MCQs, usually it is zero 0.4 grams per kilogram per day, and it's given for 5 days. So total 2 grams per kilo, 2 grams. Sorry. මේ ඇහෙනව නේද?
ඔබ
මේ 2 grams තමයි දෙන්නේ top. ඒක අපි 0.5 2 grams per kg. 0.4 grams per kg per day. හරිනේ? ඒක තමයි management එකේ තියෙන්නේ. අපි තමයි that's it for the GBS and the AIDP investigations, management, all those things. So මේක උත්තර IVIG is the first line treatment. True or false?
True.
Another? Yeah, true. CSF performed at the onset of disease.
False.
No. Yeah. Diagnosed confirmed by nerve conduction studies.
True.
No, it can't be confirmed by nerve conduction studies alone. We have to combine. So we can't take it as true. It only shows that there is demyelination, but we can't make sure that it is due to AIDP or CID. It only shows demyelination. So we have to combine all those things together. Bladder involvement occurs in the first week of the disease. True or false?
False, no?
Yeah, false. It usually does not occur, but it can occur. But even if it occurs in the later part of the disease. It occurs at the onset of disease if there is spinal
cord.
Yeah. Sensory involvement occurs in subset of patients.
True.
True, ne? Shape ne there.
Yeah.
ඉතුරු ටික මම චුට්ටක් ඉක්මනට යන්නම්. ඉතුරු ටික මම ඒවට වෙච්ච පොඩ් කේස් වලදී පොඩ්. Clinical features regarding cardiac murmur. Ejection systolic murmur at left lateral sternal suggests aortic stenosis. True or false?
True.
No, false, no?
False.
Pansystolic murmur at the apex radiating to axilla suggests MR.
True.
Opening snap in NS murmur suggested calcified mitral valve.
False.
False. Not sure.
Early diastolic murmur at the left sternal edge suggests AR.
True.
Early diastolic murmur.
Late systolic murmur at apex suggests mitral valve prolapse.
Not sure.
We'll go through the stems. So we'll go through the murmurs first now. So I prepared the document for short cases. I'll share this with you. This contains almost all the murmurs and the causes, as well as the clinical features and the management. These 4 things are the ones we are asking in our short cases. If you guys know this, you can do the CSFX case and the discussion. Very good. I will share this with you. I prepared this about 2-3 weeks before the exam. Uh, so aortic stenosis. No, we'll go through like this. I'll draw and rough this one, and I'll ask about each murmur you can hear in these areas. So these are the main four regions. No? So what are the murmurs you can have in this region? Apex.
ESM.
M
And
MR and ES.
MSMR.
MR.
Yeah. So
Yeah.
in MS, what is the type of murmur you can hear? What are you going? How are you going to describe MS?
Early does
Usually,
no no.
early diastolic murmurs are our AR murmurs.
Sorry. No.
MS,
Late.
yeah, late or mid diastolic murmurs.
Late.
Diastolic murmurs. What is the what about the S1 and S2? S1 specifically
This one loud.
loud.
Loudness.
Yeah. And the other special thing about MS, what is the other one?
Pre-systolic accent.
Yeah, precis are rooftop scene එක. S2, S1. The memo goes like this. And tuck is what? Tuck is opening S1, loud S1, and there will be opening snap as well. Okay. So this opening snap won't be heard if the valve is calcified, because the cal is not much pliable if it is calcified. No? So the opening snap won't be heard if the valve is calcified. Huh? If the valve is calcified, it's not much pliable. It is very rigid. So snap won't be heard. Okay.
Oh.
MS, MR,
Pansystolic murmur.
yeah, pansystolic murmur. It's radiates to.
Exit.
And what about S1? Loud or soft?
Soft, right?
Yeah. You guys, one of you can describe how the MS murmur occurs causes loud S1 and MR murmur causes soft S1. I think I'm going into much. It's not important, but
හරියට වැහෙන්නේ නැති හින්දා නේ.
heart second look. So in MS, there will be small amount of blood will go from atria to ventricle. So the when at the end of diastole, the ventricle is not much filled. So the cusp will be lower, like this. Cusp. At the end of diastole, the cusps are lying low because not much of blood coming from going from atria to ventricle. So at systole, these cusps go much higher with pressure. It goes larger distance from the lower to up. So the sound of closing the mitral valve will be loud. But in MR, there will be regurgitation of blood, and because there is increased blood in atria due to the regurgitation, at end of diastole, there will be increased amount of blood within the ventricle. So the cusps are not much going down at the end of diastole. So the distance it has to travel is short. So the loudness of the S1 is also not much loud. Yeah, soft. It's not important, but it's easier for me to remember it. So I usually remember that, like that. So here, lower left and left, what are the numbers? What are the important numbers?
Lower
VSD.
GST,
Yeah,
systolic.
yeah, transistolic. With the trill, usually.
Mm.
What else? If there are
AR.
AR, okay. What is the type of murmur?
Early diastolic.
Valid diastolic murmur. Okay. What else?
Mm.
What are the systolic murmurs? If there is a systolic murmur here,
Mm.
let's say pansystolic or systolic murmur, what are the possibilities? 1, 2, 3. There are three possibilities. If there is a murmur, systolic murmur in this region, there are three possibilities. This can come for a short case, that's why I'm asking. One is EST here, okay. What else?
Tricuspid
What is
regurgitation.
tricuspid regurgitation? And another one is posterior cusp MR. There are three cusps in mitral valve. No? So
Yeah.
no, two valves in mitral valve. So posterior cusp MR, due to the posterior cusp involvement, the murmur radiates from the apex to this region. So it won't be radiating much to axilla. So posterior cusp MR can also cause gives rise to pansystolic murmur at left lower sternal edge. So these three things are the differential diagnosis. So you guys have any idea how I going to differentiate clinically these three things?
No.
Ale?
VSD ഒക്കെ trill ഒക്കെ there is a trill.
Yeah, trill, and it can hear in the other places very much loud as a trill. Made it. How I going to differentiate? So
MR is
TR.
also can be heard in apex.
Okay, but that's not the main thing.
Not sure about.
So what we are doing to differentiate those two things are the dynamic maneuvers. So you know that tricuspid valve is on the right side of the heart. Okay, mitral valve is in the left side of the heart. So
Okay.
in inspiration, during the inspiration, the intrathoracic pressure becomes negative. Okay, during inspiration, intrathoracic pressure within the thoracic cavity becomes very low.
Mm.
So due to that low pressure from the venous system, large amount of blood comes into the right side of the heart because veins are coming into the right side of the heart. Okay, during inspiration, because large amount of blood coming into the right side of the heart during inspiration, those large amount of blood goes through the each of valves within the right side of the heart, which are tricuspid valve and the pulmonary valve. Okay. So when large amount of blood goes through through those valves, the intensity of murmur increases during inspiration. Okay.
Mm.
On right side of the heart, right side heart murmurs, the intensity increases with inspiration, and left side heart murmurs, intensity increases with expiration. Same thing other way. Okay.
Okay.
So in TR, in inspiration, the intensity will be increased. In posterior cusp MR, in expiration, the intensity will be increased. Okay, that's how I'm going to differentiate those two things. It can be used in the short cases. හරිනේ?
Okay.
තව තිබ්බනේ. එතකොට අපි ටක් ගාලා මේක කතාව. මෙතන what are the numbers?
Good. There. AST.
AST,
Early Yeah. Early
Uh,
systolic
ejection systolic, no? More.
ejection systolic mode.
Yeah. And another one, not much common in adults, but
PDA,
PDA is clavicle below the clavicle, left
or
clavicle usually. Other one,
pulmonary stenosis.
stenosis. So how we can differentiate is PS has the softest one, soft P2, and AST has a loud P2 usually. Okay.
Okay.
Aryan, the PS, what is the name?
Aortic.
Stenosis.
Stenosis.
Yeah.
Regurgitation usually can be heard best heard here. Okay. Yeah, best heard here. Aryan, statement.
Okay.
Ini අපි ටක් ගාලා we'll quickly go through this and go to the MCQs. So is you should I have highlighted the most common one here. Most common cause I have highlighted here. So I don't think
Okay.
we have to go through the each of things because you guys can just read it, no? Because you should know this for the short cases. I think you guys can go through that. Most of the things you might uh, know already. So we'll go to the MCQs now. It takes time. If not. Uh, so you guys told about these things correctly. Ejection systolic murmur, left lateral sunlight suggests AS, it's strong. Left lateral sunlight suggests what?
Left sternal.
Left sunlight, it's in the upper part. Ejection
AST.
systolic. Yeah, AST or pulmonary stenosis.
Pulmonary stenosis.
Yeah, pansystolic murmur at the apex area X2, opening up in MS suggested calcified mitral valve.
False.
False, calcified, not
False.
calcified. Murmur at apex suggests mitral valve collapse. This one I was also not sure, and I went through it, and it first two. I don't think we can. I am not sure about the pathophysiology behind that as well. I don't think it will come again. Late systolic
For
murmur.
D, early diastolic murmur at left sternal age is true.
Yeah,
That number G.
yeah. I told you not because I have erased that one. No, AR best heard over this region.
Yeah.
Yeah, not we can hear it in this region as well, but it's best heard over this region. It's
Okay.
clear. Komari is also true. I don't know how it occurs. I don't think it does that. So we'll go to the next question. Okay.
Okay.
So hypertension, again common, again long case, again we get questions in MCQs, SBS as well. So hypertension, the main things we need to know about are the usual, the essential hypertension management, the drugs and side effects, and then about secondary hypertension, the causes, and how we are going to investigate and manage those things. In Province's books, the secondary hypertension things have been evaluated very nicely. You guys should go through that as well. Can come as I think in our exam also they have given some patients with secondary hypertension, young hypertension patients. So you should know those things. The renovascular diseases, then pheochromocytoma, Cushing, obstructive sleep apnea, primary hyperaldosteronism, cons, all those things you should know. you can go through the provinces book. If you guys don't know about that, just let me know. I'll arrange another session because it's a long topic because we have to go through the each and every presentation as well as the investigations. So it takes a lot of time. I don't
අර
think
ඒ
that.
වගේ එකක් ඒ කියන්නේ ලෝන් කේස් දාන්න පුළුවන්ද?
Oh, long case දෙන්න පුළුවන් secondary hypertension එක. මේ අපේ අවුරුද්දේ දුන්නා 17 එකේ කොහොමද තිබ්බා. ඒකින්ද ඒක මේ දැනගන්න ඕනේ මේ මට ඒක පුළුවන් ෂේප් එකේ මං ඒක ඔබට ඔයගලන්ට ඕන නම් මං පස්සේ කරන්න. දැන් චුට්ටක් වෙලා යනවා බං ඒක ඔක්කොම කරන්න ගියොත් ඒ කියන්නේ ඒක වෙනම ටොපික් එකක්. මේ මං බේසික් දේවල් ටික මේක කතා කරන්න. හරි මේක episodic hypertension suggests fear from a cytoma.
Episodic. True.
Measurement of more than 180 to 120 is uncomplicated patient is defined as hypertensive urgency. Recognized as a cause of dementia.
Vascular dementia. And
True. Normal serum potassium levels exclude primary hyperaldosteronism.
not sure.
Obstructive sleep apnea is a recognized cause for resistant hypertension.
True, but I'm not sure.
Okay, we'll go through this. So hypertension, there are different cutoffs so in each in different guidelines. So usually there are this is a ESC guideline cutoff. So now they are talking about blood pressures less than 120 and 70, and then elevated than hypertension, which is more than 140 over 90. So for measuring of blood pressure, we can do the office or the ambulatory 24 hours and home blood pressure monitoring. So there are different cutoffs for each of those in a test. But we don't have to know about the different dose cutoffs. So the important ones are this one is important. The end organs of end organs which can get damaged in hypertension, both hypertensive emergencies as well as long-term hypertension. So in eyes, there can be hypertensive retinopathy and macrovascular those complications, heart LVH, atrial fibrillation in mice and all those things. Kidneys, glomerulosclerosis, those things, and CKD ultimately. Microcirculation, arteries and brain, vascular dementia, which you told me about. හරිනේ. එතකොට ඒ ටික තමයි තියෙන්නේ. ඊට පස්සේ secondary hypertension ගත්තොත් secondary hypertension is the blood pressure elevation due to another cause. So usually secondary hypertension, if we treat secondary hypertension without correcting the cause of it, it does not respond to the antihypertensives. It usually becomes a resistant hypertension unless we treat the cause. So mostly the resistant hypertension causes due to secondary causes. Okay. එතකොට මේකේ කතා කරලා තියෙන the two secondary causes which has been asked in this question are there are three. Pheochromocytoma, hyperaldosteronism, and obstructive sleep apnea. There are many other causes. So pheochromocytoma, idea got how it is going to present. Hello.
high blood
Tachycardia.
pressure, headache, and tachycardia. Mm.
Yeah. What is the most important one?
There are
How
three.
I,
I tried something.
yeah, palpitations, headache, and high blood
Headache.
pressure.
Yeah.
Yeah. How I going to differentiate that one from hyperthyroidism? Hyperthyroidism also can cause all those three things. So how I going to differentiate
Mm.
hyperthyroidism from pheochromocytoma?
Mm.
Any idea?
No idea.
Okay. In hyperthyroidism, our thyroxine levels, T4 levels, will be elevated day and night. There is no much variation time to time. But in pheochromocytoma, the catecholamines are released episodically. Time to time, they release
Mm.
catecholamines into the bloodstream. So only during those time we get symptoms of headache, palpitations, and increased blood pressure, but not all the time. In hyperthyroidism, those symptoms will be present during most time of the day. So that's clinically we can suspect if it is due to episodic. It can be due to pheochromocytoma. So this one is true. In pheochromocytoma, what are the investigation you can do?
Urine. Some metanet. No.
Yeah, there are two tests: VMS and
Yes.
metanexate. Both are
Yeah.
byproducts of catecholamine metabolism. Uh, so initially, what they have done is we can do both serum and urine test, both tests,
Mm.
serum or urine VMA, serum or urine metanexate. But now the preferred one is the metanexates, if possible, but it is costly. But metanexates are the better one. Okay. Then, if it is positive, you have to do the surgery and remove the chromosome. In primary hyperaldosteronism, uh, what would be the clinical picture? Can you work it out?
Cold and water retention.
Mhm.
Yeah.
And
High
Hyperkalemia.
blood pressure.
high hyper
Hypokalemia.
hypokalemia, hypo high blood pressure, hypokalemia. Usually hypokalemia, how it is present, but it is not common. But clinically, what is the symptom of patients with hypokalemia? Muscle weakness. Huh? If the symptom we are asking from the patients to not exclude but to screen whether the patients have a hyperaldosteronism if when we are taking a patient with secondary hypertension. Hypokalemia because aldosterone causes increased sodium absorption and increase decrease potassium levels. So hypokalemia and muscle weakness. තේරුණානේ?
Mm.
එතකොට මේකේ primary hyperaldosteronism, what is the screening test?
Potassium? No.
No, we do the ARR levels, aldosterone renin ratio. So usually aldosterone increases when renin increases. First renin increases and then it causes increase of aldosterone. But in primary hyperaldosteronism, there will be increase of aldosterone without increase of renin. So AR ratio will be increased in primary hyperaldosteronism. So this is the screening test.
Okay.
Okay. And there is a confirmatory test. It is a dynamic test. You have to give dexamethasone or something, but I can't remember that. When we do another session on secondary course, I will go through this and tell you guys. But this is the screen test. ARR ratio is the screen test. Okay.
Okay.
And obstructive sleep apnea, we know that it can cause that due to the episodic respiratory stress, it can cause hypertension as well. So the other one is the hypertensive urgency. So hypertensive emergencies, there are two: urgency and emergency. Urgency means the blood pressure is more than 180 by 120, but there are no features of end organ damage, like no eye changes, no heart failure, no acute kidney injury, no strokes, no seizures, anything. But if there are any one of those occur with increase of blood pressure more than 180 to 120, we call it as hypertensive emergency. Okay. So this same is also true. And we know that the hypertension can cause vascular dementia. So it is also true. And normal potassium does not exclude, but we know that the screening test is ARR ratio. So we have to do ARR levels to exclude primary hyperaldosteronism. And obstructive sleep apnea cause resistant hypertension. What is the definition of resistant hypertension?
After using two or more drugs for with some period of time, I forgot.
Usually it's when the patient is on maximum tolerance.
Mm.
3 antihypertensives, one should be a thiazide diuretic, one should be a diuretic, and still the blood pressure is not controlled, then we call it resistant hypertension. Okay. So for resistant hypertension, first what we are adding is spironolactone, and if it is not responding to that as well, then we are adding beta blockers and other second line agents. Okay.
Okay.
හරි නේද මේක එන? අලේ
ඔව්
සේෆ් නේද? ඊට පස්සේ radiological features. Lobar pneumonia, Philhook sign. Philhook, I don't know how to spell that. True or false?
Not sure.
Bronchiectasis, yeah, bronchogas.
That is true, right?
IPF, honeycomb appearance.
Sure. Sure,
Yeah.
Pleural effusion, horizontal airflow level.
True.
False.
Pneumothorax, absent lung markings.
Don't know about this.
Ale?
True,
So I got some pictures from the permit of that for this one. Yeah, this one. So and we had a session from, I think, how the Udari madam did the session, no, for us. Okay. So in chest X-ray, so you guys know, no, there is that the right hemidiaphragm, left hemidiaphragm, and the cardiac shadow, and the chest lung marking. So what are these white markings? What are those?
Bronchus.
Dharma?
Blood vessels.
Blood vessels, huh? Not bronchus. ඒක මටත් මහත් පටලගෙන ඉතියේ සෑහෙන කාලයක්. Not blood vessels, not bronchus or bronchial tree, it's blood vessels. Because bronchial tree should be in black color because air is shown as black in X-rays. No, air is shown as black. Solid material are shown white. So the white things are blood vessels, not bronchial tree. හරිනේ. එතකොට this one is the this is normal cardiac shadow. You can see that there is some definition of the cardiac shadowing and the lung shadowing here. But if there is consolidation in this region, which is let's say about the those things called middle lobe, no, this is middle lobe. No?
Yeah.
If there is middle lobe consolidation, when in consolidation we know that the density increases and it appears as white. So if it is this region is also appearing as white and this is always white, so there is not much definition of this margin like this one. So this is what we call the Silhouette sign. Okay.
Okay.
If there is right lower lobe pneumonia like this here, this one, we may not see this diaphragmatic border properly. Like it will be like this. There will be no definition between these two things as well. If there is right lower lobe pneumonia. Okay. Ale තේරුණාද?
ඔව්.
That is also called Silhouette node.
Yeah, it's also called Silhouette sign. It's Silhouette.
Okay.
Anything is Silhouette. Silhouette occurs when there is lack of definition between two surfaces, two areas which has two different consistency. What I told before. If this region becomes white, also becomes white, the border between the lung and the heart will not be much apparent like this. And if there is a consolidation here, this area will be red, and there will be no proper definition or proper margin between the abdomen, which is the diaphragm, and the right lower lobe, the lung. So it will be also like this. Okay. හරි නේද? ඊළඟට air bronchogram. So you guys can see in this one, the usually the lung should be like this, no? Like this. There are dark areas and white markings, vascular markings and dark areas. This dark area is mainly created by the alveoli which are filled with air. So when there are air.
Can you repeat it a bit? I got disconnected.
Okay. So in normal lung, so this black area is created by alveoli which is filled with air. So air shows as black in X-ray. So we get black background, which is alveoli filled with air with white vascular markings. Okay. So if there is a consolidation, in consolidation there will be fluid within the alveoli. Okay.
Okay.
In consolidation there will be fluid within the alveoli. So if there are fluid, the black area will become white. But there is only fluid within the alveoli, not within the bronchial tree. Okay. Bronchial and bronchioles. Bronchi and bronchioles. There will be still air within the bronchi and bronchioles. So those bronchi and bronchioles will be in black color. Alveoli will be in white color, which gives rise to the background of white color. Did you understand?
Can you explain one more time that air bronchogram?
Usually, this is the usual one. This region there is black background and white vascular markings. Can you see?
Yeah, yeah.
Yeah. So the background is created by the alveoli. Okay, always.
Okay.
So in a normal person, alveoli are filled with air, which is shown in black color in an X-ray. Okay.
Okay.
So in a normal person, the background will be black with white vascular markings. Okay. In a patient with pneumonia, these alveoli are filled with water or pus or anything like uh, fluids. Okay.
Mm-hmm.
So when I told you that the background is created by alveoli. So when alveoli are filled with fluids, the background will become white because fluids will show in white color in X-ray.
Yeah.
But this fluid is filled only the alveoli, not the bronchi and bronchioles. The bronchi
Mm.
and bronchioles are filled with air. So there
Okay.
will be white background and there will be black markings of bronchi and bronchiole,
Okay.
like this one. Here, this region is entirely mostly white, and there is some black markings like this. Okay, so that is what we call the air bronchogram, air within the bronchi.
Okay. Okay.
අල්ලේ තේරුණාද?
ඔව්.
හරි. එතකොට we can see the air bronchogram when there is consolidation or fluids within the alveoli, which occurs in pneumonia, not in bronchiectasis. Bronchiectasis, what happens is there is irreversible dilatation of bronchioles and bronchi, not fluid-filled alveoli. So air bronchogram can be seen in consolidation. ඊළඟට this is ring shadows. Ring shadows කියන්නේ මොකේද?
බ්‍රොන්කියෝලයිටිස්.
Yeah, bronchiectasis and bronchiectasis අනිත් එක මොකක්ද? Other sign?
And like.
Fram track signs, yeah.
Yeah.
Fram track sign, fram line shadows and ring shadows. කියන එක හොඳට පේන්නේ in a CT like this. හරිනේ?
Right.
In idiopathic pulmonary fibrosis, so ILD, there will be honeycombing in CT. We do a HRCT, high resolution CT, and there will be honeycombing like this. Okay, no?
Okay.
The other one is pneumothorax. Can you guys see that in this one there are vascular markings, the white area going almost up to the periphery. These markings
Yeah.
goes almost up to periphery. But in this side, these vascular markings does not reach the periphery, ends around here. And also you
Ah.
guys can see that there is a marking like this, discrete marking like this as well.
Mm-hmm.
So, and this region is filled with what?
Yeah.
Ear.
Yeah. If this region was white, what can this be? If this region is white, entirely white, what can this be?
Pleural effusion.
Pleural effusion, massive one. What else? And the lung is like this.
Lung collapse.
Brother?
Lung collapse.
Lung collapse. So in both lung collapse and pneumothorax, there will be no vascular markings in the periphery. Okay? හරි නේද?
ඔව්.
Yeah.
ඊළඟ අනිත් එක තමයි effusions. So දාලා නැත්නම් effusion එකක් වුණොත් දැන් fluid will be accumulated in the low dependent lowermost part. Right? So usually if we are seeing through a bottle or glass, we know that the the topmost part of the topmost layer is like this, no? The fluid, the topmost column, like I inhaling can but I'm not sure about the proper English term. There is a glass of water like this, and but if we are seeing from a side, the topmost part will be seen like this, no? Then have you seen? Ale, then
Oh, yes.
Yeah, yeah.
yeah, it occurs in this one as well. If there is only fluid accumulated within this region, the upper part will be like this. If there is air also, with air and fluids both are there, this margin will be like horizontal. තේරුණාද?
Oh.
ජර්ණ තේරුණාද? අලේ
Yes, yes, I got it.
අන්තිමට කිව්වේ මොකද්ද මේ
හරි නේද?
හොරිසොන්ටල් එන්නේ මොනවා නම්ද?
air and fluid. ඒ කියන්නේ hydroneumothrax.
අහහ
air plus water
ෆ්ලුයිඩ්
තිබ්බොත් fluid තිබ්බොත් horizontal. fluid විතරක් නම් මෙහෙම.
ඒ right.
නියම මොකද්ද? effusion එකක් විතරක් නම් මෙහෙම. effusion only නම් මෙහෙම. effusion plus ඒ කියන්නේ hydroneumothrax නම් මෙහෙම.
Sorry, I got disconnected. You just explained about the pleural effusion, right?
Yeah.
Okay, sorry.
If there is only pleural effusion, it will be like this, and if like this, if there are hydroneumothrax, which is air plus fluid, it will be like this. හරිනේ?
හරි.
ඒක තමයි MCQs. shape එකෙන් මොකක් ප්‍රශ්න තියෙනවද? Any questions?
නෑ.
වෙලාව ගියා.
Thank you.
මේ තව තියෙනවා අර වගේ මේ ඔයගලන්ට මොකක් හතරක් දාගෙන තියනවා නම් පස්සේ කරනවා නම් අවුලක් නැහැ. මට නම් අවුලක් නැහැ.
ඉවතයි වා. අවුලක් නැහැ කරනවා නම්.
මම ටග්ගාලා කරන්න දෙනවා. Dharma, is it okay for you if I go through the SBS as well?
Yeah.
I'll quickly go through it.
Okay.
So this one, උත්තරේ බලන්න එපා. 33 years old female presented with ptosis on left side. 33 years female, ptosis on left side more than right side. ඒ කියන්නේ asymmetrical. While watching television, reading, double vision. Double vision means extraocular muscles are involved. Symptoms worse towards evening, which shows us there is fatigability. Eye spec test was positive. Treated for respiratory tract infection a week ago. Best treatment to rapid improvement of a symptom. Eye spec test දන්නවද කොහොමද කරන්නේ කියලා? Any idea what is the diagnosis is?
ඒක myasthenia gravis නේද?
Myasthenia. And making up the you can get the diagnosis from the things they have been given. They have given female patient, 33 years female. So autoimmune diseases are more likely in these patients. And ptosis, asymmetrical ptosis. So we know is usually symmetrical ptosis. There are causes of symmetrical ptosis and asymmetrical ptosis. In myasthenia, usually there is asymmetrical ptosis. And double vision, which occurs due to the extraocular muscle involvement. And worse towards evening, that is the most important one. It shows that there is fatigability. And ice pack test we do for myasthenia gravis, and when there is ptosis, we put the ice pack over the eye, and the weakness improves after that. And respiratory tract following a respiratory tract infection. So this has occurred. The trigger for myasthenia gravis has been the respiratory tract infection. So next one we want to know about is the treatment. So the treatment wise, there are two aspects of treatment: symptomatic and etiological treatment. So symptomatic treatment, we are treating only to improve the symptoms. And for etiological wise, we have to there is autoimmune process. So we have to reduce the autoimmune or the antibody formation. So we have to basically we have to give immunosuppressants. So for symptomatic treatment, we have to give a style called anticholinesterase therapy, which is with pyridostigmine or neostigmine. But we do not use neostigmine. We can use neostigmine or pyridostigmine for symptomatic treatment. For immune suppressant therapy, which is the treatment for long-term treatment, we can use corticosteroids with prednisolone and with these other immunosuppressants as well. And immunomodulators like IVIG, flex, and thymectomy also can be done as well. ඒක තේරෙනවද? තේරුණාද? Did you guys understand?
බා
Ah.
ඩොක්ටර්ස්
So
ලයිට්
next
එක
one,
එනේ
මොකද්ද? මේකද?
එනේ ඔව්
එතන මේකේ උත්තරේ what is the answer?
A, right?
Yeah. හරිනේ. ඊළඟට යන්න.
යා
ඊට පස්සේ මේකේ මේ තව ටිකක් තියෙනවා pathophysiology නම නම් මම ඔයගොල්ලන්ට එවනම් ලොකුවටම ඕනේ. I send this document to you guys. Question 2.
ඒක බං ගොඩක් ඉම්පෝටන්ට් එකක් නම් කරත් කමන්නේ
Myasthenia MCQ නම් දෙන්න පුළුවන්.
එහෙනම් චුට්ටක් කියන්නනේ
I'm a Tagalog. So myasthenia, this is disease of neuromuscular junction. Again, this is from Chandler's lecture. So there are neuromuscular junction disorders, presynaptic and postsynaptic. We don't know. We only need these two: myasthenia and OP poisoning. We can OP also can be asked. So in myasthenia, we know that this is a autoimmune condition. And there is autoantibodies produced against nicotinic acetylcholine receptors. So there will be destruction of these receptors, which can lead to paralysis, weakness, autoimmune destruction. So epidemiology, we know that it is more common in females. The early onset run, late onset run, it is common in more after 40, it is more common in males. Pathophysiology, there will be autoimmune antibody production against postsynaptic acetylcholine receptors, and the receptors will be destroyed. So this acetylcholine can't be bound to the receptors because there are no receptors. So in treatment, what we do is we increase the acetylcholine levels at the neuromuscular junction. So even if there are symptomatic treatment, even if there are the reduced less number of acetylcholine receptors, but if there is high acetylcholine amount, the total transmission would be increased. Ideally, what we should do is we should control the destruction of these receptors. For that, we use immunosuppression with prednisolone. Uh, and for symptomatic management, we increase the acetylcholine levels in this the synaptic cleft. For that, we do acetylcholinesterase inhibitors. Acetylcholinesterase breaks down acetylcholine, so we inhibit that process. So by doing that, we increases acetylcholine levels. හරිනේ දාලේ තේරුණාද?
Oh,
Yeah.
That is the basis of management. So these things and this one is important clinical manifestation. So usually there is ocular muscle involvement uh, and it causes diplopia due to extraocular muscle involvement and limb weakness will be there and the patient will get usually the difficulty in getting up towards the evening symptoms like that and bulbar weakness with dysphagia and dysarthria and respiratory muscle weakness as well. One thing you should know is the myasthenia gravis does not affect the pupils. Huh? It does not affect the pupil. It's an insignificant point. It can affect the extraocular muscles, but not the intraocular muscles, not the pupil. හරිනේද?
oh,
හලෝ.
Mm.
Okay.
Yeah.
Uh, and Amity. Pupils, bladder, bowel, heart muscles not affected. Because the receptors are different, not the nicotinic receptors, and some other receptors there. Alright? No
Yeah.
sensory deficits because it is pure motor type, and tender reflex are usually normal, but it can be there can be fatigability as well in there is reflexes as well. So subtypes there are ocular myasthenia, generalized myasthenia. So it is if the weakness is confined to ocular muscles, it is ocular myasthenia, and it is there is ocular and other weakness like facial or other limb muscle weakness. It is generalized myasthenia. However, usually even it is ocular or generalized myasthenia, usually the first to affect is ocular. Even in general myasthenia, usually the first symptoms are the ocular muscle weakness symptoms. හරිද?
Mm. Okay.
ඊට පස්සේ some patients can have thymic hyperplasia. We know that thymus is the place where there is antibody production, and so some patients undergo thymectomy if it is not responding to treatments. As investigation wise, ISPAC test can be done clinical test and neurological the nerve conduction studies and all those things. And acetylcholine receptor antibodies levels can also be done. Investigation wise, ISPAC test make up. And the troponin test we don't do that currently. And management we talked about this one. And මෙන්න මේකත් බලන්න. Meiosis is a feature. True or false?
false ne?
False. Pupils are not affected. Excess
Mhm.
depolarization accounts for paralysis.
Cut for paralysis.
False.
False.
Yeah. Excess excess depolarization occurs accounts for paralysis. True and
Open spectrum ne?
වෙන phosphate තව එකක් තිබ්බා.
Mm.
Tetanus.
Good.
Pyridostigmine is an acetylcholine receptor agonist.
Antagonist, no?
Acetylcholine receptor agonist, it's true. Acetylcholine esterase inhibitor. Acetylcholine esterase inhibitor.
Okay.
Pardon. No. This is false. I missed that. pyridostigmine is a acetyl cholinesterase inhibitor. හරිද?
Okay.
So ultimately it increases the acetylcholine levels. හරිද?
බ්‍රෝ ඇගොනස් කියන එක හරි කියලාද දැන්?
ඒක මේ acetylcholine
රිසෙප්ටර්ස් වලට ඇගොනිස්ට් එකක් තියෙනවා.
ඇහෙනවද?
එහෙනම්
Hello.
මා පොඩ්ඩක් ඩිස්කනෙක්ට් කරනවා මට. මේ හරිද? ඒක තේරෙනවද?
ඒක ඇහුන්නේ බා.
Can you tell again?
Pyridostigmine is a acetylcholine esterase inhibitor. It inhibits acetylcholine esterase. So it increases acetylcholine levels. So it acts as an indirect acetylcholine receptor agonist. Indirect, but not a direct one.
Okay.
හරිද?
ඕකෙලල් පෝස්ට් එක.
ඒක better to leave it මං හිතන්නේ. හරිද? මේ concept එක you guys can understand.
Yeah.
Symptoms are least in the morning. Symptoms are least
True, no?
Anti-acetylcholine receptor antibodies are pathogenic.
Yeah. I mean, what does pathogenic mean?
ඒ ටික තමයි pathogenic means it is the cause of disease. Pathogenic means
Yeah,
cause
right.
of disease. Yeah. හරිනේ? Go to the second section. 19 years old female resides in hostel, presented with drowsiness to the emergency department with PCS of 8 and high fever for 3 days. Next stiffness was there, but there is no skin rash. What is the next step? What is the diagnosis you think? 19 years female,
Meningitis?
resides in hostel, drowsiness, PCS 8, high fever 8 days, 3 days, neck stiffness, no skin rash. Diagnosis?
Encephalitis?
Yeah, meningitis or encephalitis, no?
Yeah.
Yeah, there are no focal neurological signs. What are you going to do next?
Antibiotic, right?
Yeah, not easy, not immediate lumbar puncture.
Yeah.
MCCT brain, no, we don't have time for that. And antibiotic, what are you going to give?
ඒ පොඩ්ඩක් බෝකෝ ඒ කියන්නේ ලම්බ පංච් එක මේ ඒ ඇන්ටිබයොටික් කල් යන හින්දා කරන්නේ නැද්ද නැත්තම්
ඒ කියන්නේ ලම්බ එල්පියක් කරන GCS8 high fever තියෙනවා. එතකොට අපි එල්පියක් කරන්න තා කොච්චර වෙලා කරින්න ඕනද?
ඒ හින්දා
Yeah.
මචන් මේ මම දැන් තමයි පොඩ්ඩක් ආවේ මේ ඕකේ බං අර GCS අඩු හින්දා කිගයි කියලා ගන්නත් පුළුවන් දෙයකට හේතුවක් විදියට LP කරන්න බැරි වෙන්න.
ඒකද GCS මට මතක නැහැ අර එක්ස්ක්ලූෂන් ලිස්ට් එකේ ඒකෙදි focal neurological signs තියෙනවා නම් කරන්නේ recent seizure තියෙනවා නම් කරන්නේ අර site එකේ infections තියෙනවා නම් කරන්නේ GCS law එකක් තිබ්බා exclusion
ඔව්නේ
GCS law less than 14 දෙකොහෙත් තියෙනවා නම් කරන්නේ තිබ්බා මේක අර මේ feed එකේ තිබ්බා ඒක තමයි ඒකත් ඒක වෙන්න ති ගොඩක් හිතුව ගන්න තියෙනවා හරි නේද
Yeah.
So what are the antibiotics you are going to give?
Ceftriaxone and metronidase. What should
Metronidazole we don't give now. Usually
Then the
ampicillin,
G,
yeah,
ampicillin.
listeria. I think ampicillin covers listeria or listeria.
Mm.
The main in it also covers one organism which is not covered by ceftriaxone. I think, as far as I can remember, I think it is listeria. Not we are not using metronidazole for any CNS infection. I don't think it's any
Okay.
case.
Okay.
So we discussed about these things, no?
Mm.
Ampicillin for listeria. Alright, we go to the next question. So 40-year-old lady, 40 years, hyperkinesia for 6 months, adopted, not aware of family history, depression for long time, now has involuntary movements and restlessness, most likely diagnosed.
අන්ටින්ද
කොහොමද කියන්නේ?
Hyperkinesis.
We can go with the exclusion method. If we are not sure about one thing, we can go with exclusion. So if meningoencephalitis does not occur for a period of 6 months, it's usually acute one, and it does not usually occur for 6 months period. So it is out. Motor neuron disease, we know it is a moment. It is there will be mostly muscle weakness. The ALS, amyotrophic lateral sclerosis, there will be muscle wasting and muscle weakness, but not hyperkinesia and other things like involuntary muscle movements, except that muscle twitching thing. Low motor neuron again. Low motor neuron. Sign muscle twitching and fasciculation. Fasciculation. Except for fasciculation, no other involuntary movements in motor neuron disease. Parkinsonism, we know that the mnemonic tremor, rigidity, akinesia or bradykinesia, not hyperkinesia, and postural instability. So in this, the bradykinesia or akinesia is the significant one, the pathognomonic one, and postural imbalance occurs later in the course, and tremor rigidity also occurs. Schizophrenia, it does not suit for this picture, we know that. So the disease should be Huntington. So it occurs to more towards the 40s, 50s, and it is autosomal what? Inheritance? Autosomal dominant. So we can, if a question like this comes and we are not sure, we can't get the answer straightforward and we have not much information, we can go like this by excluding each and every step. හරිනේ?
හරිද?
මේ වගේ answer මහන්නේ or like that. Just say for 68 years old male, intermittent palpitations, dizziness, headache for 1 year. Non-patient, diabetes, hypertension, blood pressure 120 by 90, ECG short, irregular rhythm, absent T waves, suitable drugs for his management. What is the diagnosis this patient is having?
Fucosamide?
Arrhythmia.
No.
This patient is having arrhythmia. What is the arrhythmia? Irregular rhythms, absent P waves.
Irregular P wave. Yeah.
What would be AFib? No, AFib mostly. No P waves. Irregular. It can't be ventricular tachycardia, ventricular fibrillation. So this patient should be having atrial fibrillation. So how are you going to manage this patient? What is the single most important thing in this case given to decide the management?
Rate control.
What is the single most important information given for us to decide the management?
Hemodynamically stable.
Yeah, that one is also. And other one?
Palpitation.
Time.
Huh?
Time.
Time. 1. So this has been there for a long time. 1 minute. So what can be what is the complication which occurs if there is atrial fibrillation for longer period of time?
Thrombus forms
Thrombus formation is in where?
within the
Within
atria.
atria there will be thrombus formation because in atrial fibrillation there is no proper contraction of ventricular muscles. So there will be stagnation of blood within the atria and there will be clot formation. So if we turn this patient into the if we get this patient into the sinus rhythm at once, these blood clots can go into the ventricles and go into the systemic circulation and cause strokes, renal infarcts, and MIs and all sorts of infarcts. So in these patients like this who has atrial fibrillation for a long period of time, first we have to do what?
Anticoagulation.
Yeah, anticoagulation and rate control first.
Rate control.
Later on, we can do rhythm control as well. So, for anticoagulation, we can use warfarin, and for rate control, we can use beta blockers or calcium channel blockers as well. So, the most suitable answer would be amiodarone for rate control. We are not using digoxin. Again, can be used for the rhythm, amiodarone rhythm control, digoxin with them. I can't remember that. Digoxin is much not used. Sotalol and aspirin not much used. Warfarin is better. So the answer would be bisoprolol for rate control and warfarin for anticoagulation. And you guys must go through these arrhythmia management flow charts for the tachycardia, bradycardia management and the tachycardia management, bradycardia, the heart blocks, and all those things you should go through. They will ask each and every one of each and everything from here or anything. They can ask anything. නැත්තම් මම එවන්න මේ ටික දැනගන්න. ඊට පස්සේ atrial fibrillation management එක දැනගන්නවා. basically අර ටික තමයි අපි පස්සේ discuss කරමු. ඔයාලා ගියා. හරි. ඊට පස්සේ question 5. 75 years old male, 75 male, acute onset tightening chest pain, 6 hours, mild renal impairment, and hypertension. ECG, left bundle branch block, were also there in all ECG. Top 5, HS top 5, 55, very slightly elevated. Next best treatment, septic management. What is that?
An extra part?
Why?
Because this is ST elevation, so and within 6 hours.
There are no ST elevations.
Huh?
There are no ST elevations.
Oh, sorry. It's old decision.
All DC shows left bundle branch block.
Left bundle branch, yeah.
Ale.
Repeat it, just drop by in one.
The answer which was taken in another discussion was I'm not much sure about it, but how I thinking is if a patient presents with chest pain and we are sure that the clinical picture is suggestive of acute coronary syndrome, we are doing a ECG and profile levels. If ECG, there are ST elevations or left bundle ST elevations, we are treating as a STEMI. If there is a left bundle branch block, if there are past ECGs, we compare it with past ECGs to see whether it is a new onset left bundle branch block or a pre-existing one. If it is a new onset one, if there are no LBB previous past ECGs, then we manage it as the same way of a STEMI management. If there are no LBBs or STEMIs, but there are some P inversions and OST depressions, then we do troponin levels. If troponin levels are elevated, it's non-STEMI. If troponin levels are not elevated, it's unstable enzyme. The thing about troponin is the troponin level troponin is cleared by kidneys. So in renal impairment, the troponin clearance can be reduced. So the troponin usual normal troponin levels can be slightly elevated in a patient without acute coronary syndrome, but if he has renal impairment as well.
Okay.
So in this patient, he has slightly elevated troponin I levels, but LB left bundle branch block, it has been there previously as well. So the best thing I think for this patient to do is we can't give enoxaparin as if we are not sure about that yet. Thrombolysis definitely no. Prepare for PCI, we can do it, but there are no indications for a primary PCI, and I guess that he is hemodynamically stable as well. And reassure and discharge, we can't do. I think the better answer is to repeat the top 5 in 1 hour period, because top 5 levels, even HS top 5 levels can be elevated. I think about in 2 hours time we can detect, but as it is slightly elevated, what I think is better to go ahead with repeating top 5 levels after about 1 hour to see whether there is increasing trend of top 5 levels. I'm not sure about this answer. There are different people have taken different answers, but I think what I think is to repeat the top 5 levels in 1 hour. So STEMI management, chest pain management, you should know. It's a commonest long case, no? In my acute coronary syndrome, so you should know it in and out. And if possible, for long case, for common cases like acute coronary syndrome, I think you should prepare an answer. Where the question the examiners are going to ask is, after you present the case, how are you going to manage the patient when he presents in the acute setting? So you should have prepared an answer beforehand, which should be applied to each and every patient who present with acute coronary syndrome. Like I will manage this, check his vital parameters, blah blah blah, and I will take him in the blood for investigations and order urgent inward ECG. And if there are features you should have an answer for common cases like acute coronary syndrome, diabetic nephrotic syndrome, uh, generalized edema, heart failure, COPD, those things. You should have answers like that. හරි නේද නේද?
Okay. Yeah.
අලි ශබ්ද
ඔව්.
හරි ප්‍රශ්න මොකුත් තියෙනවද? any questions you guys have?
Mm. Mm. Yeah.
නැද්ද ශබ්ද?
ඔව්.
හරි හරි එහෙනම් මොකක් හරි තිබ්බොත් මේ you guys can ask from me anytime you want. අර secondary hypertension එකක් කරනවා පස්සේ කරමු ඒක තමයි long case වැට්සු කරයි ඒකත් එක්ක හරි කොහමයි කරමු
ඒ PDF ටිකක් දාන්න.
මම දාන්න හරි මම දාන්න
Thank you.
Thank
හරි
you.
හරි
Thank
හරි
you.
good night
Good night.